May I request Professor Dr. Alex Edwards, sir, Professor of General Surgery from Sri Mookambika Institute of Medical Sciences, onto the dais to chair the session. I would like to also invite Dr. M.A. Johnson, sir, to chair the next session. Thank you, sir. May I also request Professor Dr. JAYALAL, sir, to be on the dais for the next session.
Shall I start?
So, both of you are presenting. Okay.
Good morning, sir. My patient is 75-year-old.
Excuse me, again a general reminder, for the examination you are not supposed to take your PPT and all, right?
Yes.
So, in the CMEs like this also, you present without looking at your PPT. That will be better, better exercise for you. Otherwise you will be dependent on the PPT. Without PPT you cannot run. Okay?
Yes. My patient.
Let that run, but that is for the people who are in YouTube.
Yes.
You can't talk without looking.
Okay. A 75-year-old gentleman, manual laborer by occupation, from Seitunga Nallur, presented with chief complaints of vomiting for the past 3 months. Patient was asymptomatic until 3 months, after which he developed vomiting, which was initially once in 1 or 2 days, sir. Mostly during the night or when he starts brushing his teeth. Vomiting. Yes. Vomiting was foul smelling, non-bile stain, and contains mainly partly digested food particles. For these complaints, patient went to a nearby physician and he was treated with proton pump inhibitors. And since his vomiting has not reduced, he came to Tirunelveli Medical College for further management.
So the vomiters, what is more important is the vomiters, isn't it?
Yes.
So what is the type of vomiters in your case? Is it blood stained?
It's non-blood stained.
But you will have to mention that?
Yes.
Why?
In case of malignancy, there can be bleeding causing hematemesis or coffee ground.
Can it
Suppose he has an alcoholic gastritis, what will be the vomiting?
He will also hematemesis.
So the benign conditions also, right?
Or esophageal varices.
So what is it? Is a fresh blood or altered blood?
Yes,
No blood stain.
No blood stains.
Okay.
It is your case, no blood cells. Sir is asking what kind of blood you are going to expect.
In case of massive bleeding, he may have an active blood in hematemesis, and in case of minimal bleeding, there will be digestion and he will have a coffee
So
ground
hematemesis
vomitus.
is entirely different from
Blood
this
stained vomiting.
blood stained vomiters. So I am asking about the blood stained vomiters, whether it is normal blood color or altered blood color,
Dark brown.
dark brown. Okay.
Due to?
Due to act of gastric acid
With
with hemoglobin conversion.
Talk louder. Don't worry about it. This is only for learning class. We are not examining. Okay.
For conversion.
But for the sake of people who are seeing through the YouTube, unless you talk loud, it will not be audible to them.
Yes. Due to action of
You have said it's a foul smelling. What do you mean by that?
foul smelling.
It's undigested food.
Undigested food particles, partially digested.
Undigested food particle is not foul smelling. Suppose it is foul smelling, what are
What's
things
that?
you think? What is the possibility?
Due to gastric outlet obstruction.
Possibility of gastric outlet
Outlet
obstruction,
obstruction.
stasis of the food, bacterial action on that. So that gives a clue that it is not an acute just an vomiting, that this patient has some problem on that.
Yes.
So is it a projectile vomiting, non-projectile vomiting?
Non-projectile. Non-projectile.
Induced vomiting.
Yes.
So in a gastric outlet obstruction, what kind of vomiting you are going to get?
Non-projectile.
See, every statement which you are making in the history should be correlated. It is like a mathematics only. That means you are not either asking the history properly or not correlating it properly. Go ahead, go ahead. So we are not spending time on much on the.
Okay. Patient has a history of epigastric fullness after consuming food. Sir. There is history of regurgitation of food after immediately. He has like heartburn after consuming food, either solid or liquid. He has like heartburn. Sir.
Heartburn is little away from our topic, no? So he gets heartburn in. When do you get heartburn or esophagitis?
GRD.
GRD.
No, you said there is a vomiting, partially digested food, then regurgitation of the food. Both are happening.
Yes.
So what kind of food he is getting in regurgitation?
Sir, initially he could consume 1 or 2 idlis. Sir.
No, is it a digested, partially digested, or the same
Undigested.
undigested food?
Partially digested.
How can it get partially digested? Where did the regurgitation will come from? So what is the problem when you say regurgitation of the blood? See, reflux and your, that is different term, but regurgitation of the food is a different one.
Proximal obstruction.
What do you use?
Achalasia. Patient has vomiting immediately after consuming.
Is it a digested particle?
Or undigested particles?
For this patient, it's digested particles.
No, no.
Achalasia cardia,
achalasia,
it's
what is
undigested particles.
Madam?
Undigested food. Okay.
The patient has a history of loss of weight, sir, and
Loss of?
weight,
Wait.
which he confirmed by his loosening of shirts, and he also has history of loss of appetite.
The whole problem is for 3 months only.
3 months, and there is no history of.
How will you measure weight loss in 3 months?
When you say significant weight loss?
More than 10% weight loss
In 3 months?
in
Five-
That is 6 months.
5% weight loss in
5%
1 month.
in a month.
Okay.
No,
So you are interested in loss of appetite or anything else?
Satiety.
Which you are not mentioned. You are saying only loss of appetite. Is that same or different?
Difference.
different.
What is the difference?
Satiety is the feeling which we have after having the food, sir. But appetite is before having food, we'll have the hunger.
So is it significant when you have an early, the other your patient had early satiety?
Due to fear of vomiting, he has stopped eating.
Yes, sir, he has early satiety, sir. Initially, he used to take three to 4 idlis, sir. Now, even after having 1 or 2 idlis, he is having some fullness sensation, so he is not refusing to
What is
take
the significance and what is the mechanism of early satiety?
loss of receptive relaxation.
So what does it indicate?
So the growth would have infiltrated into the muscles.
Is it only that? Somebody says they have a loss of early satiety. Is it only because of the growth? Anybody? Someone has a gist. Can he have an early satiety? Pseudopancreatitis can produce early satiety?
Yes,
Extrinsic compression of the.
Anything gives you extrinsic compression also. And then, but if you put in the carcinoma stomach, early satiety. Is it mandatory that you should have early satiety?
It's a must that you have a early satiety in all cases of gastric carcinoma?
No, sir.
No.
Early satiety indicate more of a body of the tumor. So not the, if it is the pyloric antrum, not very obviously you can see.
There is no history of ball rolling movements, no history of melena, no history of hematemesis, no history of jaundice, no history of chest pain or breathlessness.
If there is history of melena, what are the causes you keep in mind?
The bleeding from the ulcer.
Bleeding from?
Bleeding from the ulcer.
Bleeding from what ulcer? What ulcer?
Bleeding from the malignant growth.
Malignant ulcer.
Bleeding from the
So postgraduate should know, can you get a bleeding when the bleeding is from the ascending colon? Can you get a melena? Yes or no?
Yes.
What is the mechanism? So here it is an acid hematin, there it is an oxidative reduction. The enzymes and the bacteria there produce an oxidative reduction and it converts to the reaction. So the slow passage of the blood, the stasis of the blood for a long time in the colon can still produce a melena. But for undergraduate they will say only upper GI is the, what is upper GI?
To ligament of tree.
Where is it?
Second part of the day.
Is it?
The ligament of teeth.
It's
See, anatomically it's where? It's in the second part of the diagram or somewhere?
DJ flexor, sir.
It goes down or goes up? Where it goes?
Up, goes up. Sir.
Okay, go ahead.
Patient is not a not a known case of hypertension.
Nothing significant, no? Okay, go ahead.
Personal history, he consumed vegetarian diet. He's a smoker for the past 50 years and he smokes around 10 BDs per day.
So, what kind of diet you are particularly want to know?
When he consumes high input of salt,
High input of salt, but you have not mentioned anything of that. You are only putting as a vegetarian diet.
he consumes food which is stored overnight, unrefrigerated food.
Okay.
Then more of
Manual,
So, is good or bad? Taking bad. So, what are the food it is bad?
Smoked meat.
smoked.
Food rich in N-nitroso components.
Why? What is the mechanism of salt? You said salt is bad. Why? You already answered, but only thing you have to put.
nitrosamino compound.
So all this put together, vitamin C is good means it reduces in nitrosamine. Whatever it is increasing, reducing, it is all basically it is in nitrosamine compound.
He's an alcoholic for the past 50 years. He has stopped consuming alcohol for the past 10 years.
So it is good.
Is he audible? Is he audible? No, you'll have to
Ta-
raise little voice.
Voice or mic you make that voice increase. So he stopped alcohol 3 months back. He developed carcinoma, which is good.
Minimum amount of alcohol.
Okay.
There is no history of gastric malignancy in the families.
Is it runs in the family?
Yes.
Yes, sir.
Yes.
Yes. Okay.
P. Catherine mutation.
Sir has written down beautiful history of which family is affected. Can you tell one famous family which is affected?
Napoleon.
Okay.
Napoleon. Very good. Okay, proceed.
A summary.
Ah.
A 75-year-old gentleman, smoker and alcoholic, came with complaints of vomiting for 3 months. Vomiting was mainly foul smelling, contains partially digested food particles with history of epigastric fullness, with loss of weight and loss of appetite. Probably a case of gastric outlet ulcer.
History wise.
History.
But you have epigastric fullness but no bowel rolling movement.
Yes.
So what to the fullness is due to the cystic is there or is the mass is there?
That is.
What do you think, sir? Somebody has a fullness. It could be a mass, solid mass, or it could be a fluid filled cavity. If he has something is a filled cavity, he will have a bowel rolling movement also.
So you told in the history after vomiting the mass, the fullness becomes less or absent. What does it mean?
There is.
No, he
There
has
is a
taken
mass.
food, the stomach is full. And then after vomiting, there is size has become less.
There is a mass obstructing the outlet.
Out. Your food, after taking out the vomiting out of the food, the fullness comes down.
Yes.
So stomach becomes empty.
So it is not a solid mass. Something.
It's not a
there.
solid mass.
So what will be the future when we? So that it relates with one and one. So if you had a little more, what do you mean by ball rolling movement?
Due to
Which ball? Football or cricket ball? No, many times we are not asking the patient properly. That is why you are blanketly saying coming and no ball rolling movement. No. When he has an epigastric fullness, is he not feeling discomfort when he is after the taking food, he is walking? Okay, go ahead.
General examination, patient is
What peculiarly we look in a
General examination.
General examination, not routine.
This is outward obstruction. So in the outward obstruction, having that in your mind, what all the general examination finding you will expect or anticipate? Number one,
Dehydration.
Right. How did you assess?
hydration,
sir, oral cavity, conjunctiva and
Skin
Skin
turgor.
skin
skin turgor, tongue moistness,
Tongue moistness.
then,
conjunctiva.
okay, then there is your
Output. Urine.
hydration,
Right.
okay,
And
then
you have put us ill nourished also.
nourishment
Yes.
and the bilk.
So nourishment, that means it's a complete obstruction.
Yes.
Why
Easy
gastric
to-
outlet obstruction produce nourishment deficit?
There is hypochloremic.
That is metabolic.
Vitamin
Which is getting
B,
absorbed in
B2.
the stomach.
Sir,
What vitamin is absorbed in the stomach?
sir, intrinsic factor is produced in the stomach, sir. So B12 deficiency may be there, sir.
So it will be presented as what?
Pernicious.
Pernicious anemia.
Pernicious.
Pernicious anemia.
So you are suspecting by history it's malignancy. You know? Any cutaneous markers you look?
Trousers sign.
Trousia's sign. In
Migraine.
carcinoma stomach.
Migratory thrombophlebitis.
No, that is more common in. Yes, you can get, but pancreatic malignancy, that's all the things much produce much. Cutaneous markers of GI malignancies.
Treslets.
Very good. What is that?
Seborrheic keratosis.
Seborrheic keratitis, sudden occurrence of that things.
Acanthosis nigra.
Acanthosis nigra. So all that you should look. As a postgraduate, when you are presenting, you should don't go by the routine. You should take there is no cutaneous markers of the malignancy. As very well you have put a dehydration is good. Okay.
ECOG score is 3.
His BMI is only 17.6
Yes.
within 3 months. What was his BMI before?
Sir,
You know, no idea.
no. Currently his weight is 46.
Previously,
Was around 60 kgs.
so 3 months somebody losing 16 kg. Is it?
15 to 20 kgs.
You said he will eat 2 idlis.
Initially.
4 idli to 2 idli only does come. That means he is
Now, after hospitalization, he can consume only liquids and milk only is like.
it's aggressively it is going.
Yes.
What is ECOG?
Eastern Cooperation
Oncology group.
Oncology Group.
Examination company.
Is vital.
Okay.
Sir, on examination,
Patient is standing,
no, sir, supine position.
supine. Standing body.
Sorry.
Because some of us examine on standing posture.
Standing.
It is standing posture or?
Standing posture.
So which position you will examine the abdomen on inspection? This is the basic thing. You should never do it on standing posture. The standard teaching, you never ask the patient to stand and inspect, stand and palpate, stand and percuss. No. You have to always lay down. Which book you follow for clinical surgery?
Das.
Thus, you make the patient on supine position. This is a common thing we do in our practice. After getting your MS degree, no problem. Before getting the MS degree, at least you have to tell the most of the clinic practice we do on standing. They are all lazy people, surgeons are very lazy.
Surgeon will never bend.
So never do that in the examination or your day-to-day practice. You will miss so many things on standing, posture and palpate. So ask the patient on lying down and spend more time on inspection. You don't straight away, so you see a mass or something like that, straight away put your finger and palpate. You do the inspection, the protocol which is given in DAS only you have to follow. Okay? Never do that in your examination.
Yes.
Your HOD will straight away fail.
Go ahead.
Tirunelveli. So you tell on lying posture, me standing on the right side of the patient with adequate exposure.
That lower black is a shadow or
Shadow.
shadow?
And up to what level you have to expose?
Expose up to thighs.
This hernial orifice is not able to see. See, these are all the things you have to be careful. Right.
Describe the abdomen.
On supine position, there is a fullness noted in
Right or the left? Okay.
that's all.
This is a supine position. Describe.
And there is a fullness noted in the epigastric region.
There is a fullness in the epigastric region.
So show me the epigastric region there. The picture. There, no. Oh, up to come down. So what is the line?
Transpinal.
Where is
Trans-
it?
What vertebral level it goes? Transpyloric line.
Lower border of the L1 vertebra.
L1 vertebra. Okay. இது அதுக்கு மேல எல்லாம் ஃப்ரீ எல்லாம் பாருங்க.
So the
Epigastrium is hollow. You
Almost
see
the
a
looks hollow. It is down.
Extending up to the umbilical.
Here the patient is on standing. No, these are all the problems, practical issues. Okay.
Umbilicus is inverted.
No, you finish the abdomen. So examination of abdomen and inspection, there are so many things. You have to find the shape of the abdomen. That is the first thing you have to tell in the examination. Shape of the abdomen. That is the first thing. Then, what else? What else? All quadrants, whether they move with respiration or not. These are all given in DAS. Whether all the quadrants, 9 quadrants move with respiration equally. Number 2. Number 3, there is any scar or any sinus or dilated veins. Number 4, any mass seen or any mass or any lump you see. Then hernial orifices, very free, you have to see the hernial orifice. Then your line, then renal angle. So there are 19 regions. Then you have to go to the supraclavicular region, axilla. These are all external genitalia. These are all the things you will have to do on inspection. Exam la, you should not forget. So 8th order your written inspection umbilicus is midline. So you are not bothered about the umbilicus. What is synovial sign?
Tenoid sign.
Umbilicus will move upwards in case of pelvic.
You don't know. It is not. There is no fixed place for umbilicus. Okay, the actors they keep the umbilicus above or below. You also can do that. So never tell umbilicus in the midline or something like that. And what is more important is the shape of the umbilicus. Whether it is flush to the surface, whether it is everter. What is the normal shape of umbilicus?
Inverted.
Inverted. Most of us it is everted or flushed. Okay.
On inspection, a mass is seen in the epigastric region of size 4 × 3 centimeters.
It is not in the epigastric region, Bob. Don't make the mistake. At least saying the picture. In the exam also, epigastric is relatively a small region.
Yes.
Very small. இல்லையா இங்க இவ்வளவுதான் வரும் இல்ல காஸ்ட் மார்ஜினோட முடிஞ்சிரும். Then you start the umbilical region.
Mass is
So
seen
you
in
told initially you told there was a VGP. Now you are telling a mass. What the patient has, whether the mass or VGP or mass with VGP or only mass or only VGP.
mass with VGP.
You are able to see a mass with VGP.
Where is the mass you have felt? In the epigastric region.
Extending up to the umbilical.
No, such a long mass is the body of the tumor. So will you get a VGP?
Such a huge VGP, will you get a mass? Will you get, then it is against carcinoma. Unlikely.
Yes.
Such a huge VGP with 4 × 4 centimeter mass. So, why it is not, it is unlikely? Malignancy and huge VGP is unlikely. Why?
Muscle infiltration will be worse.
From VGP will be, if at all there, will be
It's mild, very small.
very minimal. Okay.
What is VGP?
Gastric
Starts from where it starts and where it goes.
starts from left to right.
Right, then
About down.
Left, right.
it comes to the right, then what happens? It disappears. Is it magic? You already said it is it must be a dilated stomach, so it is slowly diffused back. Then again the next cycle starts.
wave will start.
Wave will start from there, and suppose it is having right and left it goes, or right to left it goes.
Transverse.
Transverse.
Transverse. Okay.
So you describe the lesion. Still your inspection, you are not said anything. You are not talked about the skin. You talked about the dehydration in the general examination. You are not said what is happening in the skin. Is the turgor of the skin is there.
The surface of the mass is smooth. The margins
On inspection.
on inspection the surface is smooth, margins is well defined.
All the margin, upper margin, lower margin, everything is well defined.
Yes.
Are you going to expect that to happen in a carcinoma stomach? You have a mass with the upper margin is well defined, lower margin is well defined.
Well circumscribed mass, is it possible in stomach? So some of you present in the examination VGP as a mass. VGP is not a mass. Do not present in the examination VGP as a mass. Right? Mass will not come and go, will not disappear, come again. Okay? So VGP is not a mass. It's a waveform movement only. So that will disappear after some time. It will be slowly fading off. So what do you have to see is a mass, whether it is a mass with VGP or only mass or only VGP. So I doubt whether there is
This is very important because we have seen very good students are getting caught in this. They think it is an obvious mass and they are presenting it is actually only a VGP. Okay.
And you cannot palpate VGP also. VGP cannot be palpated.
How will you look for VGP?
Tangentially means
Where do you stand?
to the right side of the seat.
VGP. VGP you have to go to the foot end of the patient. It's the only place where you go to the foot end.
It's not the eagle's eye view. It is a tangential view you are going to see.
On
Head tracing test?
the mass becomes less prominent.
Why?
It doesn't involve the abdominal walls.
Hey, how do you tell? When you head raising, it becomes less prominent or disappear. That means it is intra-abdominal. Sorry, we don't know whether it is intraperitoneal or retroperitoneal. Adhikadhan adu. Not to rule out the infiltration onto the parietal. So it becomes more prominent, it is a parietal swelling.
Yes.
Less prominent, it is intra-abdominal. So how do you know it is intraperitoneal or retroperitoneal?
On left lateral portion.
Left lateral or knee elbow? Knee elbow pandradilla namma illaya. It's almost obsolete procedure.
Left lateral you can put.
Yes.
Left lateral.
What will happen to then? Suppose there is a hernia, epigastric hernia, on head tracing test, what will happen?
The swelling becomes more prominent.
More prominent. Why?
Raised intra-abdominal pressure, the contents may come.
Suppose the reduced swelling on head tracing, it will become a big swelling.
Divarication.
Divarication.
It will become
More prominent.
Due to? So there is a
Thinned out
defect, you know,
linear.
hernia is a defect. Through which, due to the intra-abdominal pressure rise, it will bulge. That is what happens in hernia, inguinal hernia.
Pulsation is seen over the mass. What pulsation you have seen?
So transmitting aortic.
Aorta. There. But your picture shows more towards the right side. What do you feel? Aortic pulsation?
Maybe very thin,
Very thin incision.
20 kg loss in 3 months.
Significant weight loss.
Okay.
Maybe.
Mm.
So what is a contradictory thing in the finding is a VGP with the mass is less likely. Right, okay, you cannot tell. Abdomen is a
Misting.
magic box.
Pandora's box.
Pectora. Right.
Palpation.
On palpation, there is no focal tenderness.
Palpation findings problem. So inspectory findings of site and well defined margin is confirmed. How will you confirm well defined margin on palpation?
I
No, VGP is not a
still
mass.
doubt you have seen all the borders you have seen. Okay.
On palpation, mass of size 4 cross 4 centimeter, palpable in the epigastric region, which is ovoid in shape, irregular surface, hard in consistency, moves with respiration.
So what is the upper limit of the mass? You are able to reach the upper limit of the mass?
Yes.
Lower limit of the mass? Right? Right side of the mass, left side of the mass?
Yes.
All.
Okay.
Pulsation is felt over the mass. Probably.
Louder.
And transmittal pulsations. On left lateral position, the mass falls forward.
Is there a way to confirm that it is only a transmittable station?
So we have to keep both the index finger and middle
No.
finger.
No, confirm.
How do you confirm?
What do you have to do?
Left lateral position, the pulsation
Away
will
from
disappear.
Yes. Lateral position.
On left lateral position, the mass falls forward, probably intraperitoneal. Sir. Succussion splashes here.
So, when you are going to do the suction flash?
Before looking for VGPs.
Before looking for VG.
Suction flash is present, ball rolling movement is absent. How do you explain? What is suction flash size?
There is a defect in empty.
There is an obstruction, there is some amount of fluid collection is there, stasis of the fluid is there. Okay, that always will clinically correlate with the ball rolling movement of the patient. Ausculto percussion,
The stomach is dilated
how did you do?
with the bell of the diaphragm.
Bell of the diaphragm kept where?
The borders of the
Bell is kept in the border. How do you know the border?
from the
Have you done the ausculto percussion test?
Yes.
Tell me what is the procedure, how will you do?
with the back of a pencil or pen, scratch over the
Where do you keep the stethoscope?
Over the mass.
Over the mass.
Distance.
The solid mass you are going to keep that, okay?
Over the distended abdomen.
How do we know it is distended? This test is to whether it is distended or not.
from Ziffy sternum we have
Okay.
to
Keep it in the syphisternal region and
from there we have to start scratching using the back of
scratching away from the stethoscope or towards the stethoscope?
Away from this.
Away from the. Then you will mark that area. Have you marked that area? The examination, please mark that areas. So that is some of the examiners may come and see that whether you have done that test. So you need to mark that areas.
There is no other mass palpable, sir. No other organomegaly.
So where is this mass?
It all in the epigastric region.
So which part of the stomach this mass is there?
It is in the epigastric region.
No. Which part of the stomach,
Stomach.
probably? The antrum or body of the stomach? Proximal
From
unlikely.
epigastrium it extends up to the umbilical region, sir, probably due to
No, which part of the stomach?
And
That's what sir is asking.
It is only 4 centimeter you said. It cannot, your epigastrium is cubic like this. So where it is there?
Most probably, just
It's not, you can't say, if it is the mass is at the outlet obstruction, where will be the mass?
சொல்லலாம்.
Antropyloric.
Huh?
Antropyloric region.
That is what we are saying, but in the palpation, where do you feel the mass?
if it's antropyloric, it should be felt in the transpyloric plane.
Transpyloric plane,
2
midline, left side, right side,
right to midline.
right of midline.
right. So here in the epigastrium above, you are seeing. Okay.
On percussion, there is impact resonance over the mass. Liver span is 13 centimeters.
How did you measure the liver span?
So in the right side, mid-axillary line.
Mid-axillary line.
Mid-axillary line and mid-clavicular line.
From mid-clavicular line, we have to go a little obliquely.
From where you go obliquely?
Which space? Which
Tell the
intercostal
procedure.
space?
How do you do? From where to how do you start and go?
From
Just because it is a learning process, we are asking this question to you.
percussion, we start from the second intercostal space,
At what line?
mid-clavicular.
Okay.
From the fifth intercostal space, we go obliquely.
Obliquely towards
Mid-axillary.
mid-axillary line.
That's it too.
A person who is nutritionally poor, what will be the size of the liver?
Suppose you are patient, your BMI is only 17.
17 and you are 17, you said ill-nourished patient. What do you expect in the liver?
Size will be decreased.
Decreased. What is the nutritional changes that take place in the liver?
Steatohepatitis.
Fatty liver, no?
Fatty.
So it will be enlarged or
Enlarged.
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 Liver should be
So liver span will be less or more?
More.
more. Okay.
No shifting dullness.
Yes.
Was there any fullness? The abdomen was flat?
Abdomen was flat.
Flat. Okay.
And auscultation
How do you do shifting dullness?
percus from midline to the lateral side, sir.
So you percuss from the outside.
Also from midline,
So where do you start?
from center midline to left
Midline, from my mouth to anal canal, it comes to the midline.
on the umbilicus.
So for the shifting dullness, you start from umbilicus. What?
From the audience, PGs,
Shifting dullness, that means nobody is doing that.
from civistanum. From civistanum you percuss up to the umbilicus. Then go to the,
Then
ask the patient. If it is dull on palpation, you ask the patient to turn to the opposite side.
Wait for 30
Wait for
seconds.
some time. 2 minutes.
so these all are the basic tests which we should know. Okay.
On perrectal examination, normal sphincter tone, normal fecal stain, no
Louder.
no nodules felt.
Nodules. You are expecting a nodules. What nodule?
Blummer shelf. No.
Blummer cell. Where? It's a male. How do you differentiate it from prostate?
Can like the mucosa.
That is from the rectal malignancy. The rectal malignancy, you will say the mucosa will be altered. So here that, but
Gastric.
posteriorly, when you are palpating anteriorly, you can see the prostate is enlarged and nodule is also there.
How will you differentiate?
You are saying that it's a nodule, I am saying it is a prostate.
There is no urinary complaint.
Sometimes carcinoma of prostate without any urinary complaint. Urinary complaint will become only when the benign more. So the level, where do you feeling? Which is higher?
Prostate will be feeling lower.
Lower. So what you see the first, in normal individual, can you feel the prostate?
Yes.
You feel the prostate, and if there is a nodule is felt above that, then only you should make a comment. And you should feel the mucosa when it is rolling down, then only you should come to the conclusion. So what will be the history if there is a nodule is present?
Be hematochezia.
What will be the symptoms patient will have?
Diarrhea.
Diarrhea or constipation. It is not irritating the mucosa to produce a diarrhea. It is only the external compression is going to take place. Okay. What's your diagnosis?
In case of gastric outlet obstruction, probably due to malignancy.
What made you to make that is a diagnosis?
So shorter duration.
No, we are shorter duration, we are going to say it's a carcinoma.
Patient has VGP, sir. Mass felt in the
VGP is felt more in benign condition or malignant condition?
more in benign.
Benign condition.
Then your VGB is against your finding. So this is gross VGB. Okay. So you make a diagnosis of carcinoma of stomach. Which part of the stomach?
Can you once again put that picture? Show me the mass where you are seeing the mass.
Anybody else
Has seen the case?
Has seen the case? Palpated? In the valley PGs?
Anybody has seen the case or? Okay. You operated also.
Okay.
So this is our request. Go back and check elicit the VGP separately and the mass separately, if you are able to see. So how you are going to proceed? So time is short, and 10 minutes it will take.
Proceed with.
So first we will be doing an ultrasound abdomen, sir. And for confirming diagnosis, we will do an upper GI endoscopy. And if any growth is there, we will do biopsy of that, sir.
So if there is no growth, we will not take biopsy.
We will do.
So how will you make whether it is a malignant stomach or not by an endoscopy?
The pattern of ulcer.
Pardon?
Pattern of?
Pattern of?
When the rugae converges towards.
So this case, so what step you will take before taking endoscopy?
USG.
Gastric lavage will be given for the patient before.
How do you give a gastric lavage?
So for 3 to 4 days, first we have to put an white bore Ryle's tube and first empty the gastric.
What is that white bore?
16 French Ryle's tube. And we will first aspirate the gastric contents, and after aspirating we will put normal saline and we will give wash until clear fluid is drained from the Ryle's tubes.
Okay. So you are going now putting the endoscopy. So what are the things you are interested to look for?
So I will just check for the growth, sir. And if endo ultrasound is available, we can look for the depth of invasion, and also we can
Endo
look.
ultrasound. You said 4 into 4 centimeter mass.
So you want to do endo ultrasound.
So what is the indication of endo ultrasound?
T1.
T1, T2. Is it a T1, T2 tumor? According to it is a 5 centimeter mass. There is no role of endo ultrasonograph in such a large mass you are going to see. Endoscopy, what are else you want to see?
Where the lesion is.
Where the lesion?
Site of lesion.
But then
One.
Suppose in the gastric, I can say it is a benign ulcer. How will you say it is not a benign ulcer?
The rugas will be converging towards the ulcer in case of.
Or anything else?
the loss of peristalsis around the ulcer if it's malignant, sir. In benign you can see peristalsis.
This all you should say quick, one by one. What is distensibility? Okay.
Distensibility on inflation. Malignancy and benign.
Sensibility will be present in benign.
So will you pass through the duodenum, cross the duodenum through the scope?
Yes.
There is. You will be able to pass.
Is it important to?
Yes, sir.
What is it important?
To rule out whether obstruction is there or not.
No, obstruction can be, there is obstruction. Is it a full obstruction or not? If you are able to pass the scope, what gives you the value, what it gives? Some amount of nutrition is going on. There is no need to make the patient for the nutritional supplement as is not needed. If there is a complete obstruction, you can't take up the surgery. You should support the patient with the nutrition also.
Only partial obstruction.
Okay. Then all the features of endoscopy, advances of endoscopy, you must learn.
You will also do CT chest and then abdomen and pelvis.
For staging.
Staging. For what? Staging of what?
Staging of the malignancy for the neoadjuvant.
Neoadjuvant.
So I have to check whether liver metastasis and.
You are talking about the workup.
Yes, sir.
Workup.
That is CT abdomen you are going to do.
CT abdomen and chest.
Ultrasound is also giving you a value. What more value the CT will give you?
So perilesional nodes which are isoechoic and are also will be.
Very good. Isoechoic nodes cannot be done in my ultrasound. Then
Loss of fat standing between pancreas.
louder.
There will be loss of fat standing between pancreas and posterior wall of stomach. Signs of inoperability.
What is the role of diagnostic laparoscopy? Now it is included in the
Yes.
workup.
To rule out occult metastasis.
What you will do on diagnostic laparoscopy?
See for the peritoneal and omental metastasis is present or
You are only going to see
and if present we will do biopsy or peritoneal
peritoneal.
cytology.
Oh. So that is more important, not just seeing that. It is a peritoneal cytology should be also done, and of course you have to see and if there is a. So nowadays don't much use the word that it is inoperable. All that is slowly going away. Even the people have started doing for liver metastasis also, they are doing surgery.
Segmental this thing. Now previously early gastric carcinoma and advanced carcinoma. Now it is loco-regional. Early or localized, loco-regional, then advanced. Advanced also, we can attempt curative treatment.
Even for liver secondaries, they are doing a liver transplant or then and doing the section, and with a good targeted antibodies which has come, the results are very good. So the concept of inoperability is less. But when you say totally inoperable, not inoperable in the sense with a curative intent.
When there is
tell.
ascites.
Pardon?
Ascites.
Involvement of the major vessels will be there. Sir.
Cases are coming, with that stage they give neoadjuvant therapy, they are responding, they have to do. Even at that stage we can say it is a, but we don't go and operate at that time. If that neoadjuvant therapy is there, so you start with the neoadjuvant therapy, then only the surgery. So in that sense only it is operable and inoperable you are saying. Not immediately, you should put the patient, subject to the patient for, what is magic trial?
Magic trial flood regimen is used, sir. 5-fluorouracil, leucovorin, oxaliplatin and docetaxel will be given.
So that is the
Pills of
perioperative chemotherapy.
Perioperative. 4 cycles and neoadjuvant followed by 4 cycles adjuvant therapy, sir.
And you should read about molecular pathology also.
Molecular profiling, like a breast carcinoma, here also now the molecular profiling has come.
Next generation sequencing, all things PG should
HER2
read.
mutation and programmed death ligand.
Yes, PD, L1,
L1 ligand.
all things you have to read. All theory part, but they will be asked in the examination.
What is the one drug you can PDL1?
Pembrolizumab and
Pembrolizumab.
Livozumab.
The results are extremely good with that. Okay. So what do you want to do? Suppose it is operable cancer.
I'll do one D2 gastrectomy depending upon the lesion. If possible, I will do a subtotal gastrectomy with D2 lymph node.
What do you mean by subtotal?
Involving up to 80% of the stomach is removed.
How do you measure the 80%? How do you know it is 80%? Is there any landmark? What is the upper limit you keep?
The second branch.
Short gastric vessels. How many?
What is the bare area of the stomach?
Up to ascending branch of the left gastric artery.
That is
Short gastric.
short gastric. Okay.
2 we have to preserve.
So
2 you have to preserve.
Yes.
partial gastrectomy is better. So there you are going only by the, how much margin you are going to give?
Sir, for early cancers, 2 to 3 centimeter margins is given, and for local advantage, 3 to 6 centimeter margin is given.
Is it like that, or the pathological type you are going to say? What are the two common types of tumors you get?
Luminal and
No.
adeno.
Pathological type.
Microscopy pathological types.
Papillary mucinate signal.
So you get a tumor, and what is leather bottle stomach?
Lanitus plast.
What is that type?
Diffuse.
Diffuse. So for what you are going to give, margin you are going to give for a diffuse type, and what is the margin you are going to give? The margin is not same for both. So when it is a diffuse type, you have to give minimum 5 centimeter margin should be given. If it is that, you can give only a 3 centimeter margin is also enough for that. Okay. So how will you reconstruct? You have done a subtotal, how do you going to reconstruct?
You maintain the continuity. Yeah.
Rooney gastrojejunostomy will be done. Sir.
Anterior, posterior?
Anterior. Anterior.
Why Rooney? What is the advantage of doing Rooney? Why not just an anterior gastrojejunostomy?
So chance of biliary reflux is less compared to the gastrojejunostomy.
Retrocolic or anticolic?
Anticolics.
So what is the length you take?
Sir, from first we will divide the jejunum 20 centimeter from the DJ flexure, and we'll anastomose the jejunum with the stomach, and from that GJ 40 centimeter we will reconstruct the jejunostomy.
What suture material you are going to use for anastomosis?
Sir, for all layer 30 Y clear and seromuscular 30 silk.
So post-operatively?
Post-operatively,
you should know about
I can
J
give
plus.
an adjuvant chemotherapy. If I have done and not completed an D2 gastrectomy, I will go for radiotherapy also, sir.
So will you do the spleen? Splenectomy will you do?
No, sir.
Not always.
Not.
So what are the nodes you will remove in D2?
D2 level 1 and 2 nodes, which includes the right and left paracardiac along the lesser curvature. That's a, and
You are doing a subtotal. Is it necessary that you are going to remove the level 2?
from along the lesser curvature and from greater curvature and suprapyloric, infrapyloric, and the nodes along the celiac, common hepatic, and left gastric, and nodes along the hepatoduodenal.
So which nodes you will not remove?
Splenic.
Splenic ILR you don't remove.
Oh.
Station 10, you don't remove.
12?
What do you mean by adequate lymphadenectomy?
At least 16 lymph nodes should be removed.
Minimum.
Sir.
Be harvested.
Oh. So any post-operative adjuvant therapies you give?
Yes, sir. Postoperatively 5-fluorouracil or capecitabine based therapies can be given.
Is it radiation or chemoradiation or chemotherapy? Which you
If
prefer? now?
D2 lymphadenectomy is complete, we can go with only chemotherapy, sir. If D2 gastrectomy is not, lymphadenectomy is not complete, we will go with chemoradiations.
What about OG junction growth?
How will you classify
OG
that?
junction.
Sievert's classification, type 1 is the lesion which is from 1 centimeter to 5 centimeter away from the OG junction, and type 2 is from 1 to 2 centimeter.
What is the important thing you will have to do in OG junction? You will have to do a frozen section.
Yes, sir.
Then proceed to find out the invasion.
Suppose your supraclavicular node is involved here. I will look for, because we are not mentioned about the supraclavicular node.
There is no supraclavicular.
No supraclavicular.
But in your examination, you have never mentioned that. You have not mentioned your. So how do you? Why do you want to look at the supraclavicular node? Why do you want to look at the supraclavicular node? How from the stomach the tumor is going to the supraclavicular node?
So the thoracic duct drains into the junction of the.
How it goes to thoracic duct?
From a reflex.
What is thoracic duct and where is it? Now I am asking from the stomach how it goes to thoracic duct first. What is cisterna chyli?
That drains the.
Which vertebral level? Cisterna chyli, which vertebral level?
What is it?
From abdomen only starts, no?
Yes.
How it goes to the thoracic duct goes through the which opening?
Which hiatus?
Which hiatus? You must know the direction, how it goes medially, when it turns to the side. The,
Esophageal hiatus only, no?
so why there is supraclavicular node is coming? Where is it come?
The reflex.
Reflux. What do you mean reflux? Reflux is coming back through the same route. So if the thoracic duct is going, if there is a reflux, it will come through the thoracic duct only. Is that is a reflux you are meaning? So in that area, perhaps area where not only the thoracic duct but also the supraclavicular lymphatis are also coming there. And so in a when a retrograde flow is happening not through the thoracic duct, through the superficial, the supraclavicular lymphatis. That is why it is getting the nodes around the junction. Where it opens?
At the junction between the subclavian and the.
Suppose the situs inversus is there, stomach is on the other side. Where do you get a node? Otherwise, right side chest, how it drains, lymphatis, how they are draining. All are coming to the thoracic duct. Any, right side lymphatics drains where? So This junction is there only on the left side or right side also you have the same veins? The right half of the head and the chest drains separately into the right side. It's not draining into the left side. Okay. What is the prognosis? Prognosis for this patient.
5 years survival is less than 20%.
So any scoring for prognosis, prognostic value, any scoring system available? What is CPS scoring?
CPS.
Any idea?
Number of PDL1 tissues divided by
In macrophages, tumor cells as well as lymphocytes divided by number of actually positive tumor cells into 100. The score is less than 5, it's of good prognosis. More than 5, bad prognosis. Outcome, CP scoring. And what is the importance of surveillance? That also you should know. So the patient is having early gastric malignancy. The patient doesn't develop any recurrence or something. Within 5 years, you can tell him disease free. But most of the recurrences in advanced, loco-regional and advanced will come within 2 years. Before 2 years, it will come mostly in an advanced disease or locally advanced disease. But early you can wait up to 5 years. And after 5 years, book says there is no need for surveillance. You can tell him disease free in early.
Where do you get a recurrence?
Anastomotic site is the most common. Anastomotic sites.
Anastomotic site. Gastric bed is the most common. So the patient with there is no bleeding, there is no ulcer, but he is so anemic. What is the cause for anemia in a case of a gastric carcinoma? One is any bleeding, ulcer, it comes down. There is no bleeding. So what are the things observed and what is necessary for observation of?
You only told in the history.
Ferrous to ferric, is there is anything important? There will be achlorhydria or
achloride.
so the acid is needed for conversion of the ferrous to ferric, and that is necessary to become the hemoglobin creation. So once there is iron deficiency, anemia will come, not because there is a supply is not there, but conversion of the ferrous to ferric is not happening because of the achlorhydria. So you are getting at the anemia. Okay, I think it's a time we are done.
Time, yeah. Good.
Thank you.
Well done.
And we are prepared. Thank you very much. And thanks to Professor Pavida Madam also for your presentation. The most important in the clinical examination is how you are examining each clinical case, clinical examination. Like liver dullness, shifting dullness, looking for the mass, looking for the auscultar percussion, succession flash. All these please try to do clinical. Now that is most importantly we will give. That all is going to guide. That is a basic. And if you clear that, then all the other advancements are there. Just because you talked about advance, and if you are failing in the clinical examination, it is dangerous. Okay. Thank you.
Thank you for the presenters. We extend our sincere gratitude to Professor Dr. Alex Edwards sir and Professor Dr. JAYALAL sir and Dr. Johnson sir for chairing the last session.